Thank you very much, Sue. I would echo, my gratitude for this opportunity to share with everyone on the call about what we have to offer at Baystate with regard to sedation for GYN procedures. And I've been here at Baystate since 2013, and one of my big missions and big drivers of what keeps me focused in patient care is trying to improve what we do for patients to try to meet their needs as best as we can. And so that's kind of led me to developing the GYN Procedure Unit. And with that in mind, we'll get started. I do want to say that I do not have any disclosures to make financially. On a talk like this, I think it's important that you know that I have no financial incentive from any of the different products or procedures that I'm going to be talking about. Everything here is free of any financial ties. And if I use brand names in the talk, I do not have any relationships with any of those companies either. I would just be talking about brand names for clarity, to use names that most people on the talk may have already been aware of. So if we take ourselves to the gynecology visit, this can be very anxiety provoking for patients. They may be wondering, what kind of exam do I need today? Am I going to need a pap smear test? Will the examination or any testing that I have be painful? And those kinds of questions. And so we realize at Baystate that gynecology encounters can be anxiety provoking on their own. And so this is, an opportunity for helping our patients be more comfortable with care that is necessary and indicated, but can be provided with good pain relief according to the patient's needs. And so here's a list of some common gynecology procedures. So the first one on there, you see pelvic exam or pap smear. And even this might sound very simple, but there are a lot of patients out there who one barrier to care is that they don't do well undergoing a pelvic exam or a pap smear. And faced with that, we have a responsibility to offer them pain relief, anxiety relief, so they can have indicated tests like a pap smear for their general health and not have to worry about, I'm going to have to endure great pain or just be refused a greater pain relief options for whatever reason. This is again a common exam that we perform in gynecology, but it can be very anxiety provoking. And you see some other examples there: intrauterine device insertion, and we're going to talk about that in greater detail. But then endometrial biopsy is a very common procedure that we perform to test for reasons behind abnormal bleeding that a patient might have. And this can be done in the office, but sometimes for a patient can be painful. And so we want to be able to pay mind to that. If someone has an abnormal pap smear, they may need a test called a colposcopy and biopsies, or a uterine evacuation, where we empty the uterus if necessary for a variety of clinical presentations. And so just to present what are IUDs, I don't want to assume that everyone on the call knows what I'm talking about. They are devices that you see a couple examples here that are a little bit larger than a quarter, the coin, a quarter that we all have held in our hands. And the one that you see on the left is a example of a copper IUD. And then the one on the right is an example of a levonorgestrel, sometimes called a progestinite IUD. The brand name of the one on the left, the copper IUD, is Paragard. And then on the right, those would be either something like Mirena or Liletta brand names. But they're very similar in size. They're all T-shapes like this, and they, when inserted to the uterus, can help provide excellent contraception. And so on the next slide, I just have to say that they're small, they're T-shapes. The main reason why patients might use them is they want to have several years of excellent contraception for pregnancy prevention. But a lot of the IUDs can also be used to help minimize or even eliminate menstrual periods, which is, for a lot of patients, a really attractive feature of intrauterine devices. And so the IUDs are a common type of birth control that we offer our patients. And the vast majority can have IUDs placed right in the office. And so the next thing I want to talk to you about is, okay, how do we do that? What goes into the procedure? And so this is whether we do an intrauterine device insertion in the office or under sedation, the procedure itself is unchanged. The provider could be a physician. It also could be a midwife or a nurse practitioner, physician's assistant, would do an exam to tell how the patient's uterus is tilted. And that's out of safety so that we know which direction your uterus points so that we can place the IUD in that direction. Just as a matter of making sure that if anyone's worried about how their uterus is tilted out there in the audience, it actually does not matter at all, apart from if you're having a procedure like this, how your uterus tilts. It doesn't affect things like your periods. It doesn't affect pregnancy. It's kind of like saying your hair color is brown. It's just a feature that's unique to you. But if we're doing a procedure that involves placing something inside the uterus, then we want to know which way it points. And next, we place a speculum, and this can be painful for patients too, or make patients have a lot of pressure sensation, and so we're cognizant of that. Then we place a grasper on the uterus, and this can cause some cramping. So an area of need for pain relief or anxiety relief. Then we measure the uterine length, and this involves placing a very thin measuring stick inside the uterus to measure how long it is, so we know how deeply to place the IUD. The next step is placing the IUD itself. And then all IUDs that are used today have a very thin pair of strings that attach to them and are meant to sit inside the patient's vagina so that when it's time to remove the IUD, all that needs to happen is grasping the strings and a gentle tug removes the IUD. Also, if a patient is having a gynecology exam, the examiner can easily see they have an intrauterine device as well. After we cut the strings, then we remove the instruments from the patient's vagina, and the whole procedure is in the neighborhood of about 10 minutes, maybe even a little bit less. So these are kind of the common steps of intrauterine device insertion, and this, along with things like endometrial biopsy, things like a pap smear, can all be done in the office, and for decades have been. But a reasonable question is, well, hang on, what options are there for pain relief? And in the office, we have things like Motrin or Aleve, which are over the counter. We have something called a paracervical injection of local anesthetic, and I'll talk about that more in a second. But this is where we inject medication to help reduce sensation of cramping. And then for anxiety, we can prescribe oral medications such as Xanax for anxiety. But if we do that, then we also need to make sure the patient has an adult escort home, because after taking something like Xanax or Ativan or something like that, then it's not really safe to drive for at least a few hours. So that brings me to the paracervical block. And in the cartoon, this is kind of a cutout of where the injection is placed through a patient's vagina. We're using a needle to try to target those yellowish structures that are the nerves that feed into the uterus and deliver sensory back to someone's brain. And what we're trying to do is use local anesthetic, so we're blocking any signals of pain or cramping so that patients have less pain and cramping during a procedure. And when done in the office, this definitely works, and it helps reduce pain scores, and especially for patients who've never been pregnant or who are young, let's say less than 25 or 26 years old. These are clearly beneficial for patients, but we will offer it to anybody who would like to have a paracervical block for the office procedure as well as a procedure under sedation, so that we can maximize pain relief. And this whole process of a paracervical block takes about a minute to place, and then we wait a couple minutes for the medication to have better effects. So, and once again, we're at a talking about sedation. So I think you all know where I'm going with this. Is this enough? And there's actually a study published in the medical literature looking at, well, how do IUDs and IUD insertion, how does this find what happens on social media? What happens on things like YouTube, TikTok? What is the general public saying about this? And when they looked at the top 100 TikTok videos that had a hashtag IUD on them, 97% highlighted pain or side effects as the main concern of the video. So clearly, it's an area that patients don't feel like they're getting the attention and the care they deserve when it comes to things like pain relief and anxiety relief. And so for ourselves, like me and providers in women's health, we have to ask ourselves, are we doing enough to minimize pain? Are we offering options for what patients can have for pain relief and letting patients decide, okay, this is what I'd like to do for myself? And again, I will say that many patients will do just fine in the office when they're having a lot of these procedures performed. But the real matter, the real object here is to make sure that patients have all the options that they want so that we're not leaving anybody behind with regard to receiving services comfortably. And in that regard, it is a meaningful question to ask out of fear or trepidation because of the pain that might experience. How many patients out there skip IUDs as a contraceptive method? How many patients just say, no, you know what, I know I can't bear the insertion, so I'm just not going to consider it. How many more patients could we reach if we offered pain relief more than what we can do in the office? And then just as important, or even more importantly, how many patients don't come to women's health providers for routine pap smears to check for cervical cancer because they don't tolerate pelvic exam as well, and they would appreciate something for pain relief that's more than what we can do in the office. And if we look at this is a screenshot from YouTube a couple of weeks ago. You can see in the search box, I put in IUD insertion experience and just found out what came up. And you can see this is an area that there are lots of videos about. And by and large, these are talking about patients and their own experiences. And so there's no right or wrong here. Patients are sharing what they experienced. And if you go through them, a lot of the common themes are anxiety, fear, pain, and just something that's really crucial is the idea that their provider minimized the pain or tried to kind of brush over the pain they might experience. And then now the patients are wondering, do I need to have am I worried about trusting my provider when they tell me or counsel me about things that I should be experiencing? So again, it's out there. This is a very common concern for patients. And not just for patients, the media has found this as well. And this is a article from the New York Times about a month ago that the federal government, hearing kind of patient concerns, has published guidance to really charging providers with the responsibility to help their patients find adequate pain relief needs for procedures such as IUD insertion. And so if the federal government has caught wind of this, then it's an important issue and one that's garnered a lot of attention. And in the same publication, the New York Times also spent some time really asking the same question that we're here today to talk about, which is, are providers doing enough? Why does it hurt so much to get an IUD? Can we be doing more? And why not? And so this is an issue that's front and center. And the great news that I have to share with you today is here at Baystate, we have options. And I do want to give credit to the women that are in the picture with me. They're both nurses named Jennifer, and they are part of the GYN Procedure Unit team. We actually work together today, and we do great things for patients and helping patients meet their healthcare goals comfortably. And the bottom line is we have heard you and we've listened. Women deserve options for anxiety and pain relief. Doesn't mean that everyone has to have sedation for their procedure, but it would be nice to have that as an option. And we want to make sure that we're helping patients who are avoiding care or delaying care because of fear. We want to help bridge that gap so that patients are having the full range of contraception options and getting necessary tests and screening exams comfortably. And to share a little bit of history, before I came to Baystate, I trained at Boston Medical Center, and they offered for a long time they've offered sedation for procedures. And I took the lessons I learned there in training, and I said, you know what? Here at Baystate, there's no reason why we can't do the same. And so through the work of a lot of people in the OBGYN department, in the Chestnut Surgical Center, and in the nurses and the hospital, we made this happen. And so it was a really big labor of making sure this got off the ground and making sure that we're here for patients who need our services. And so how does this all work? So you might be thinking, okay, this all sounds good. How does one actually get to the GYN procedure unit? So it all starts when you and your provider in the office, could be your physician, could be your midwife, NP, PA, decide on a procedure. And you decide together that this is something that's to benefit your health, or something like an IUD, which is a fantastic contraception option. And you can discuss performing it in the office, which for most patients, again, is very reasonable. But if when talking about what to expect from pain, sedation is desired, well then great. We want to be able to see you in the GYN procedure unit. And the wait time or the length of time it takes to get into the GPU has historically been pretty quick. For the vast majority of patients, we can get you in within a couple weeks of time. And so we generally don't have a big long wait. And we do have if we have demand that shows that patients are demanding the service, then we can of course look at growing. But we can get patients in reasonably quickly because we know that we want to make care as expeditious as possible. And what you receive in the GYN procedure unit that's different than the office is that we use two medications for sedation. One is called Versed, and you can see the generic name there. And that's an anxiety-reducing medication. It's related to medications like Valium, Ativan, Xanax. We also use fentanyl, which is an excellent pain-relieving medication. And for anybody in the audience who thinks about fentanyl and has only really heard about it in the sense of being used as an illegal substance or being used as a street drug, fentanyl has a number of legitimate uses. And the difference here when we use it in the hospital is that we know the dose we're using and we know that there's nothing else mixed in with it. So when we use fentanyl here in the hospital, it comes right from our pharmacy, and it's been dosed. We know that it's safe, and we use doses that are safe for patients and have been tried and tested for patients. You might be asking, well, what if I need a little bit more than what the general dose is? We have the availability to add on to that if patients need it. But the doses that we use are good for pretty much, I would say the close to everybody, but we do have the availability to give more medication if we need to. And the procedures that we perform in the GYN procedure unit tend to be 30 minutes or less. And this is perfect because that's about how long the sedation lasts for. So the anesthetic and the procedure length match really well. Is this safe? Well, I hope that you know I wouldn't be doing this if it was unsafe or that we were gambling with patients' lives. It is absolutely safe. And before coming to the GYN procedure unit, we evaluate every patient's medical history to make sure that they don't have any medical problems that would make sedation something that we can't safely provide. And throughout the entire visit, a patient's vital signs are monitored. And certainly during the procedure, during sedation, they're monitored at a minimum, for things like blood pressure every 5 minutes, and things like heart rate, things like oxygen level in your blood is monitored continuously. So who qualifies? Like, what are the health requirements for coming to the GPU? So Baystate has a rule that if you're going to receive sedation and you don't have an anesthesiologist present, that you need to have a body mass index or BMI less than 40. And so we look for that when we're screening patients. Patients can't have any significant heart or lung issues. The common things like hypertension, high blood pressure, or asthma, as long as they're well controlled, we can still see patients in the GPU that have high blood pressure, asthma. But if a patient has more significant heart or lung issues, we'll examine those closely and figure out where the best places for them to receive care. One big one is because someone gets sedation in the GPU, they do need an adult who can bring them home. Patients aren't going to be safe for at least a few hours to get to certainly drive or get themselves home on their own. And so when patients come to the GPU, they need to have identified an adult who can bring them home from the hospital. And that can take the form of taking a private vehicle, taking a shared ride like an Uber or Lyft, take a bus. It doesn't really matter as long as that adult is present, so that they can safely get you home. And then we also make sure that patients understand that sedation does not mean asleep. So some patients will want to be fully asleep for their procedure. That is available through the operating room, but not through the GYN procedure unit. And I'll touch on that base in a second. But to kind of reassure everyone out there, the level of sedation that patients receive kind of puts them in the middle of between being fully awake and fully asleep, kind of like a middle of the road drowsiness that patients may be technically awake, but they don't care as much about what's going on, and their pain is much better relieved. And it's not dangerous if someone spontaneously falls asleep, not a problem. We'll be watching breathing, we'll be watching heart rate, oxygen levels, but most patients don't fully fall asleep because we don't use medications that are that strong. But what if I want to be asleep? That's a very reasonable question. Your provider, if they're not already a gynecologist, can refer you to one, and that a gynecologist can talk to you about the procedure in the operating room, where the availability of deeper sedation, general anesthesia is possible, and that's an option too. The downside of the operating room is that there is more competition for time, so the wait for the operating room may be a little bit longer. But if that's what is needed to get the patient the care they need for that level of pain relief, then we will schedule the procedure and wait for the time. Now, who is going to be taking care of you in the GYN procedure unit? So these are the components of the team. So you have an OB/GYN physician, like myself. You have an OB/GYN resident physician. And the reason I put a star there is it's a reasonable question to ask, well, do they need to be there? And I would argue that yes, they do, for a couple of reasons. One is Baystate has a strong mission of educating the next generation of healthcare providers. And then specifically for this service, offering procedures under sedation, I want to make sure that I'm teaching as many of my junior colleagues as possible how to do this so they can, if and when they leave Baystate, they can act like seeds in the wind and carry this message that we can do this for women across the nation, across the globe, if we put our minds to it. So I want to make sure that this message, the capabilities of this, are to as many people as possible. There are at least 2 nurses, one who's watching over patients in the pre-op, post-op area, and then one who's in the sedation unit during the procedure, and then a medical assistant who's helping us set up and with equipment, and is there as an extra pair of hands to help us with procedures. And the care team is a great core team of people who really are dedicated to making sure that patients have excellent care. Now, it's also a reasonable question. You know, you sound great, Dr. Kattan, but what if I would really rather have a female physician? Good news. I have a colleague whose name is Dr. Dodge, who is excellent and is a lovely person. And we share the GPU coverage duties about half and half. And so you are more than welcome to indicate, hey, I'd rather have a female physician, and we'll make that happen. And so we're very cognizant that many patients may desire that, and we want to pay attention to that. So what happens on the procedure day? So what this means, because you're receiving sedative anesthetic, you need to have no food and most liquids for 6 hours before the procedure. So to make sure that your stomach is empty of foods and liquids that are not water. Things like plain water or clear liquids, things that you can see through, like Gatorade, apple juice that doesn't have pulp in it, those are okay. Cranberry juice as well. If it's a liquid you can't see through, like milk, or has bits in it, like cider or orange juice, then those are off the table. But if they're completely clear, then you can drink those up to 2 hours ahead of time. And you can take home medications as prescribed. So if you do take a medicine for high blood pressure, continue to take it. If you take thyroid medication, continue to take it. If there's a medication that we ask you not to take, we'll tell you that, but those are pretty rare. At check-in, a GPU nurse meets you, confirms your health history, places an IV. Then you'll, and this may be a little bit out of order. You might have changed into the gown before the IV, but you'll change into a gown. And for some procedures, we do want to make sure that patients are not pregnant. And so we may ask you to give a urine sample. Some procedures, we don't need that. Some that we do. So for a lot of patients, that's the only test they need. If you need to do blood work ahead of time, we will make that known to you well ahead of your procedure. And the procedure itself, you and the team go into the procedure room. There's a timeout, and what that means is that the entire team stops what they're doing. We read your name, we read your birthday, we read your medical record number, and we read the procedure. We confirm your allergies, and then we give time if anyone has any concerns that they can speak up. And if everybody is on the same page, then we go on with the procedure. The IV medications are given. We do any pelvic exam that we need to. The procedure is performed. And like I said, additional medication is available. The procedure nurse is available to you throughout the entire procedure time at your bedside. Patients sometimes would like to just talk about anything on their mind to help them get away from what's happening. And certainly, we're happy to talk about whatever a patient might have on their mind. Some patients want to just zone out, listen to some music, close their eyes. All that's perfectly fine. We want to make sure the patients are comfortable, and things like listening to music, things like being silent or just closing eyes or talking, happy to do all of those things. If vital signs are monitored throughout the entire process so that we know that you're breathing normally, that your heart rate's normal, your blood pressure is normal, and your oxygen levels are normal. We have the availability to supplement oxygen in the GYN procedure unit. We have medications that can reverse the sedation medication in case someone has an effect from them that's stronger than we anticipate. And we have those available. We have in 9 plus years, we have really only had to use anything like that a very handful amount of times, because the doses of medication that we use don't cause such deep sedation that they affect breathing or oxygen levels. Warm blankets are available. Again, we understand and we get that if someone's in a gown, they may just be cold, and so we want to make you comfortable that way. And the total time in the procedure room is usually about 20 or 30 minutes. After the procedure, you'll stay with us for about 30 minutes. The point of this is to make sure that any bleeding you experience remains light. Any pain that you experience, we can, of course, treat with things like Tylenol, like nonsteroidal anti-inflammatories to help with pain, and that your pain is reasonable for the procedure that you had, and that the anesthetic wears off as we expect it to. Some patients will need an antibiotic after the procedure. We'll give you that in the recovery area. It would be uncommon for you to need to have further antibiotics after leaving us. And then we discharge you to home. And the only requirement there is that you need to have an adult who can bring you home. And if you bring a person with you, an adult with you to the visit, you want them next to you during the preoperative portion of the visit, they're very welcome. We also understand that some patients don't want their escort knowing why they're having a procedure or any details about their health history. You can also leave them in the waiting area. We're not going to tell them what procedure you had. You can tell them as much as you want, and we'll just make sure that they know that you're safe and when you're ready to go home. So what does the rest of the day look like? So you can't work, you can't drive, and we recommend that you don't use things like alcohol, marijuana, and don't make any big life decisions. So after you've had sedation, I don't want you going to sign mortgages or buying a car, things like that that are big life altering things. So the rest of the day is really for you to rest and recover. After that, you really generally have no restrictions on your activity starting the next day. Immediately, not even just the next day, but immediately after the procedure, things like walking and up and down stairs, that's all fine. Things like lifting and exercise are going to be according to how you feel. So there's not going to be any medical danger from lifting or exercising, but you may feel tired, you may feel sore, and so you just want to take things more slowly. For most procedures, there's not a prohibition of having vaginal sex, but what we say is listen to your body. And if you need some time before having intercourse, then take it. But generally speaking, there's not a medical reason why you can't have sex when you want to after the procedure. And fundamentally, listen to your body. We will tell you if there's any specific do's and don'ts about your activities afterwards. Generally speaking, those don't really extend past the day of the procedure with things like not working and not driving. We're happy to provide work notes so that if you need time from your job, we're happy to write you a letter to that effect. Most procedures that we do will have a recovery time of something like 1 day, 2 days, or 3 days. Oftentimes, though, patients will return to work the next day. So we just want to make sure that patients know they may still be sore, but it's safe to work after a good night's sleep. And ibuprofen and Tylenol are the mainstays for pain relief after the procedure is over. One of the things that we ask is that if your pain is so bad that these things are not working, then we want to hear from you, because that's not normal. And thankfully, it's not very common either. And so for follow-up, most patients don't need to return for a physical follow-up visit because complications are rare, and most of the time, you don't need to come for a follow-up exam as long as you feel well. And mainly, we want you to call us if you have any of these rare problems, such as fever, heavy bleeding, where you're soaking through a menstrual pad more than once an hour, if your pain is uncontrolled with things that you can buy over the counter or home remedies like a hot pack, we want to know about that. That's not normal. Or if you can't keep food and liquids down, you're throwing up, you're excessively nauseous. We want to make sure that to figure out what's going on there, because that shouldn't be a common side effect of any of the procedures that we do. If you have any test results that come from the visits, we'll call you or use the portal if you prefer, the Baystate patient portal, to report any test results. Otherwise, we'll ask you to return to your referring provider for ongoing care, and we'll be in communication with them as well, so that they can resume your care in the office for anything that needs further attention or management over the long term. How about coverage and cost? So the nice thing is the procedures that we perform in the GYN Procedure Unit are all things that generally can also be performed in the office, and they're considered outpatient procedures, and they're in the eyes of insurance, they're glorified outpatient office visit. Now, so if we do generally check to make sure that your insurance doesn't require pre-auth or pre-authorization. It's not very common because the procedures are all outpatient, meaning you go home the same day, but we'll check. Depending on your insurance coverage, you may have a copay or deductible. So we will ask you to check on those sorts of questions, because by contacting your insurance company, you'll be able to determine will you have a copay for this service? Will you have a deductible? And we're happy to provide the billing codes that we plan to use for your service in case your insurance company asks you. But generally speaking, these services are all covered, and the coverage tends to be quite good, because everything we're doing is considered an outpatient procedure, and insurance likes that because it's less costly. So I want to start wrapping up by saying that here at Baystate, the GYN Procedure Unit team, the Department of Obstetrics and Gynecology, we care about you. GYN procedures, like pap smears, like IUD insertion, like colposcopy, like endometrial biopsy, are necessary to maintain health, but they don't have to be painful. Patients don't have to expect to suffer through them just so they make sure that they're safe medically and they're keeping up to date on their intended screening exams. So the GYN Procedure Unit is here for you. How to contact us? So referrals are best made through your provider. If they are within the Baystate system, we can see their notes easily. They can send us messages easily. If they don't work at a Baystate provider, then we'll ask them to contact us by phone, so that we can get any records that we might need to review, and then we can learn how to contact you so that we can offer you dates and times to come for your procedure. And you can see the phone number that's listed there. That is our office number, and you can ask for the GYN Procedure Unit team or nurse to kind of take down what the desired service is. And again, these are questions that sometimes patients won't know, so that's why we like the referral coming from a provider or their office, so that we can make sure that we know exactly what's being asked. And with that, I want to say thank you for your attention. Thank you for spending part of your evening joining me for this chat. And I am very happy to take any and all questions.
Thank you, Dr. Kattan.
That was really terrific and informative. And we do have some questions in the Q&A box. But I just want to remind everyone in our audience that if you have any questions, to type them now, and we'll start addressing those. But really, Dr. Kattan, great talk. Our first question is, aren't paracervical blocks just as painful as the IUD insertion?
Great question, and thank you for asking it. So, paracervical blocks can sting when they're being given, but that sting goes away within a few seconds, and then you have the lasting effect of the lidocaine, which is why that this is an option. This is not something that we tell patients, oh, you're going to need this. This is an option because we want to make sure that the patients know that, listen, there's going to be some discomfort when we start using this, but we expect the benefit to be greater than that initial discomfort. And patients are free to say, you know what, I don't want to do it. And that's fine. Absolutely fine. This is not something anyone has to have.
Terrific, thank you. The next question, is the sedation similar
To what's used for colonoscopies, twilight-ish?
Excellent question as well. Usually in colonoscopies, they are using an additional medication that goes by the name of propofol. And this is not something that we use in the GYN procedure unit. It is a deeper anesthetic, and colonoscopies are supervised by either an anesthesiologist or a nurse anesthetist because because of that deeper anesthesia, someone who is capable of placing an airway and a breathing tube is available at a moment's notice. So it is not the same as what's used in colonoscopy. It is a little bit lighter than what's used in colonoscopy, but it's definitely noticeably different for patients than nothing than an office procedure without sedation.
Terrific, thank you. The next question, what percentage of patients
Want to be fully sedated? And does preference vary by age or ethnicity?
That's a great question, and I'm not sure if there is a great research question that a research study that has answered that. But I think your question is exactly the point, which is now that I think that in the last couple of years, this has really started to gain a lot of steam as an issue that we have to pay attention to. We can no longer just say, it's only going to take a second. Let's just do the procedure and get it over with. And so I think that a lot of that research is probably ongoing, or we've yet to see. And so the direct answer to your question is I don't know. But we want to offer this so that patients know it's a service that's available to them.
Thank you. And this next question
Is related to that. Is there any research on the number of women who don't get screenings due to anxiety?
And I'd say the same thing. I mean,
right.
It's a very, very similar question, and I'd say that I think probably the best answer to that is that it remains to be answered in an evidence-based fashion. But there's no doubt that the issue is out there and does come across the minds of lots of women out there.
So the next question is
sedation covered by most insurances? But you did cover that in your talk that they are, and they cover quite well.
Yeah, and if you need to double and triple check that before going forward, that's absolutely fine. We don't want you to be surprised by some huge bill. So if it takes you a moment to talk to your insurance company, especially if you have a copay or deductible based on what we're doing, that that ahead of time. We're happy to see if there's any pre-authorization that's necessary, and we're happy to share the codes that we use for diagnoses, for billing, so that you have that to report to your insurance company if necessary. I'd say that it's coverage is not usually a problem. It just depends on how much cost sharing, if any, is the patient expecting to have.
This next question is relatively
similar. Do you accept referrals from outside of Massachusetts? Example, Southern Vermont, and if so, do you find that insurance will cover that?
And so we do accept referrals from outside of Massachusetts. The most common place we get them is from Connecticut. And so if we had someone who is coming to us from Vermont, from New York, et cetera, then we would do our due diligence and see, for that pre-auth process, we would get in touch with the insurance company and say, we're here based in Springfield, Massachusetts. Will the patient's insurance cover that? And just make sure from our end that there aren't any pre-authorizations that's necessary. And then on your end, as the patient, we'd ask you just to check with your insurance company. If they'll allow you to receive services physically in Springfield, Massachusetts, generally, that should be a good predictor that you'll be able to receive services at the GPU. I do see that there was another question just above that I wanted to comment on.
Yep. Please go ahead. Yep.
Yeah. So the question is, are there sedation are the sedation options for endometrial biopsy, colposcopy, uterine evacuation the same? Yes. The medications are the same, and generally speaking, they will work at the initial dose that we give to patients, and more is available if necessary. But that's a very nice, the starting dose that we use is very nice for the majority of patients. And it usually is less of an issue of what procedure is happening versus the patient herself and her own characteristics, and making sure that all her comfort needs are met.
Terrific. Thank you. The next question.
Why isn't nitrous oxide offered more as a sedation method?
Fabulous question. So this actually has been looked at in research, and for the things that I've been talking about the most, things like IUD insertion, uterine evacuation, endometrial biopsy, the data is not very good with regard to using nitrous oxide on its own for pain and anxiety relief for those procedures. And so because the research has been done saying that it doesn't really work that well for the procedures that we're doing in the GPU, we don't do it. And so if there seemed to be a beneficial effect to adding that on to the sedation medications we use, we would look at that and consider it. But the research has been done to suggest that it actually doesn't add to the benefit.
Very good. Thank you. Next question. How much time does sedation
add to the procedure time again?
Yeah. So the procedure itself, so the administration of sedation takes about a minute or two to administer the drugs. And those are administered in a very controlled manner so that patients have a gradual exposure to the medications. And then really that's really the only additive points. So maybe 2 or 3 more minutes added to it. The other additional time comes from a very brief transportation from our preoperative area into the procedure room. It is a matter of about 50 feet, so it's not a long distance. So that might add another minute on either end. But so we're talking about maybe another additional 5 or 6 minutes on the procedure itself.
Very good. Thank you. The next question.
Does deep sedation always mean the patient is intubated?
It does not. So deep sedation means that patients are generally not responsive. They're not talking. They're sedated to a level where they're not conscious, but they may not need an airway to breathe as long as the oxygen can be supplied to them externally. But just again, just to make sure that I'm not causing any misunderstanding, we don't offer deep sedation in the GPU. Deep sedation would be offered in an operating room setting, and that does not mean that every patient is going to be intubated, but you will have an anesthesiologist or a nurse anesthetist caring for your anesthesia needs, because the chance of needing an airway placed is much higher than if you use conscious sedation, which is what we use in the GPU.
So if you don't mind,
I have a question via email. This person says, I have an IUD since 1981. I'm 72 years old. Since the string is retracted, I've been too nervous to have it removed. Would I be a suitable candidate for this type of procedure?
So great question. And I want to be careful about, because I have not seen you as a physician. I have not been able to examine you and kind of ask a little bit more of your life story. And please don't put it in a chat or an email, because what I would say is, and we can if you look me up on the Baystate website, if you look up our office, happy to set up an appointment with you to consider that question, so that we can talk about what to do, if anything, and kind of to present you with your options for care.
Perfect, thank you. Excuse me, the next is a comment.
Thank you, Dr. Kattan. Your presentation was very informative and thorough. I appreciate the value this webinar provided for the community.
And I appreciate that, Barbara. Thank you so much for your comment. Thank you for joining us. I hope this resonates, and I hope that we can reach as many patients as possible.
The next question: does the body ever reject an IUD?
Yeah. So what I think that you're talking about there, I'll answer it a couple different ways. So what I think you might be meaning is, can an IUD ever be expelled or fall out after being placed, or become in a position that causes pain or other problems? And the answer is yes. The chance after IUD placement that an IUD can fall out or become what we call malposition, meaning in the wrong position inside your uterus, is about 3 to 5%. And so generally that will show itself to a patient because the patient will experience way more pain than they expect, or their bleeding will be very bothersome. And so if someone is asking, or if someone is reporting those kinds of symptoms, then we'll investigate, okay, is your IUD in the right place? What I just want to make sure, if you mean, does it reject it because of like an allergy or some insensitivity to the medication in an IUD, those are really rare. Allergies to IUDs, whether it's copper or hormonal, very, very rare. And so that's less of a worry. But malposition or expulsion is about a 3 to 5% risk. And for patients who want a checkup visit afterwards, happy to set that up for you, so you can come in to the office and see a provider who can make sure your IUD is in the right place, 2 months or so after it's been placed.
Very good, thank you. The next is a comment: very reassuring presentation. Thanks for listening to women. And I would concur with that. It looks like we have one final question here. How long are Mirenas effective for? Is it 5 years or 8 years?
Fabulous. So the answer to your question is that they're effective. They're FDA approved, meaning that the FDA has certified that they are effective for at least 8 years. When Mirena came first to market and use in the United States, it had a 5-year effectiveness label. But over the years, that's been looked at through research to see, does it last longer than that? Because patients noticed that their bleeding patterns were still very, very light, even at 5 years, 6 years plus. And so research that's been done show that they're effective for at least 8 years. And I've had patients who have gone even longer than that and have had no bleeding at all. And so I suspect at that point that the IUD is still working for them, but I offer them removal and replacement to be sure if they'd like to stick with that same device. Another IUD that you may hear about that is the same thing as Mirena medically is called Liletta, and that also is good for 8 years. The copper IUD that we've talked about in this presentation, the Paragard, is FDA labeled for 10 years, but it looks like it is good for at least 12. And none of these years mean how long you have to use it, because if you don't like the IUD or want to become pregnant or any other reason for having it removed, you can have it removed whenever you want. But this is how long you can keep it with the confidence that the contraceptive effect will be there, that you don't have to worry about pregnancy.
Terrific. Good flexibility. It looks like we
Have one more question popped up if you wanted to.
Yeah, it says, I see that
Okay.
I've heard IUDs can become embedded in the uterus. How would you know if this is the case? Excellent question. So just to kind of unpack that a little bit for the audience, embedded means that some part of the IUD has become stuck in the uterine wall. So the uterus is made out of muscle, and rarely the IUD can become stuck in the muscle. Thankfully, this is pretty rare. I mean, this is less than a 1% chance of this happening. But how would you know? So the way that you might know this is if a provider tries to remove your IUD and it doesn't come easily. That could be one clue. Or if the patient is having bothersome symptoms like pain that it's not going away, bleeding problems that are not getting better over time, we can send you for an ultrasound to try to figure out where is the IUD and can we find more about why it's causing those problems, and then figure out, okay, do we think it's embedded or not? And and so when we add up all that information, we can figure out what intervention is the right thing to do and how can we remove it. The good news just in general is that even if IUDs are suspected to be embedded, we can still get them out. But we talked to you about considering your own unique circumstances. How do we do that? What methods are involved, and what's the proper setting? The office, somewhere like the GYN Procedure Unit, or the operating room.
terrific. Dr. Kattan, we're at
Time, and we really appreciate your expertise and for helping women. We really are grateful for your time, and to the audience for providing these great questions. Thank you very much.
Yes, thank you very much for this opportunity, Sue, and I've really had a great hour, and thank you very much to the audience for joining me.